She's 55-year-old, and she came here for the MRI pelvis. And means I will just show the image. I will not question anything. So we see these perianal masses here. These are kind of T2 heterogeneous intensity, not like very T2 bright. So this mass we see like it's between the internal and external anal sphincter, nicely sitting here. Then another mass we are seeing here anteriorly near the perineal body, and one more I see lower down here. So this patient then again on post contrast sequences we are seeing like intense enhancement of those lesions here. All these lesions are enhancing, and on top of that I am seeing some lesions in the muscles also, like gluteus maximus here on left side, adductors, and all the way down on the right gluteus maximus here. So any thoughts about this? What do you all think? Or
The ones in the muscle, are they blending in with the muscle? Because one of them looks super T2 dark, like it could be a leiomyoma, but I've never seen like leiomyomatosis syndrome, I guess.
yeah. So actually we don't have that like bigger field of view for like to say like non-contrast on non-contrast how they present. Like here it's like blend. Yeah, here you see this the lesion in the adductors, which is again like T2 heterogeneous intensity, I will say hypo to mixed intensity. So these patients, these lesions, like they did biopsy on these lesions, and it turned out granular cell tumor. These masses, and they were diagnosed in 2016. And at that time, the like physician told patient that we need to excise these masses, but patient was not ready, and patient presented today with some other complaints, health complaints. And again they found this like hard like mass in the perianal region. So then again we scanned the patient. We don't have like 2016 scan, but we have this recent scan where we are seeing the masses in the perianal region, which appears to be increased in size as per the physician's note. And also we see lesions in the muscle.
Can you tell
So
us more, and anything you know about granular cell tumor? I guess I don't know anything about that. Like which one is the
so
primary? Oh, perfect.
So yeah, so I just made like 2 slide presentation. So just like to think about differentials in that region. So we can get like lymphoma in the perianal region. Then another is perianal myxofibroma, which like sometimes shows central areas of necrosis and usually like arising from the kind of myofibroblast cells in the perianal region. Then perianal leiomyoma, which shows like heterogeneous enhancement and arising from the muscles of the anal sphincters. And another entity is perianal angiomyxoma, which shows kind of lamellated appearance on these titulated images and shows intense enhancement, and also has like myxomatostoma on T2 weighted images. And some other teaching points about granular cell tumor which I found are like these are rare neurogenic tumors originating from schwann cells of the peripheral nerves, and they show S100 and CD68 positive like on pathology lab evaluation. And on the microscopic, their characteristic feature is large polygonal cells with abundant eosinophilic granular cytoplasm. The common locations to think are like skin and GI tract. In the GI tract also we see more in the esophagus and the subcutaneous tissues. No like definite age group. It's like a wide range. We see here 18 to 75 years age. So they can be benign and malignant. And if malignant, then we will see metastasis to lungs. And as the physician suggested to the patient, the main treatment is surgical resection. But if it is malignant, it can recur. And the one which I showed is perianal GCT, and which like when I went through the some of the literatures and the papers, it seems that it is very rare. And right, like up till now we just found 40 cases of perianal GCT.
Great.
So
So it seems like it's related to Schwann cells, which makes sense because it looked kind of like they could be neurogenic, but it sounds though it's the malignant version.
yeah, so like now they are planning to like excise these masses. So I don't have the histopath of these lesions now. If I see anything difference like malignant conversion, I will definitely update about that. So right now I have the results from 2016 biopsy.
Got it.
Yeah. Okay.
Excellent. Thank you.
Yeah. Thank you.
Okay. So this is a middle-aged man, and he came back with, let me just take out the overlay. He came in with a lot of abdominal pain. This is the first CT we have, the first study we have for him. You want me to, like,
Is it coming from like the liver or the stomach? Let me.
You can see there are multiple liver lesions, right? And you can see bulk of it is replacing basically left hepatic lobe and caudate lobe. And there it is on the portal venous phase. Let's see. Here's the arterial phase. Okay, and I'll give you subtractions. All right. Anybody wants to? Do you want me just to go through stuff, or you know?
I have no idea what it is. It looks bizarre.
It is bizarre, but you can see that on subtraction, things are hyper-enhancing, hypervascular, right? And if I give you the subtraction from later phase.
Neuroendocrine is in the differential?
The differential for sure, but there's something about it. There's a reason I keep the, and you can see that this is subtraction for portal venous phase, and you can see that there's washout and all these things. So this is a hypervascular plasma enhancement. So I keep the preconscious images up for a reason, because that cinches the diagnosis.
Is it a melanoma of some sort?
Say it again?
Melanoma of some sort?
Yeah. You can see how T1 hyperintense everything is. And so when you see things that are this hyperintense, I mean, obviously when you see hyperintense areas, you think about something hemorrhagic, but you can see here, even the tiny ones are completely T1 hyperintense, and they enhance. You know, if you look at the subtraction images here, you can see that subtractions, right? These enhance, right? So if this was hemorrhage, it would just not be enhancing. So you know, you see, so these are not hemorrhagic. These are they have intrinsic T1 hyperintensity because of melanin. This is probably like the most, like I've seen multiple, you know, melanoma mets, and usually like you've seen either none of they're just hypervascular. You don't really see T1 hyperintense signal, or few of them have T1 hyperintense signal, few don't. But this is like probably the most I've seen where everything is hyperintense in T1. And this man has remote history of ocular melanoma. And so that's and I don't dare to show you the brain MR, like, you know. And then
cool. I haven't seen one that huge.
Huh?
I haven't seen a met, like a melanoma met that huge. Like, you know, like usually you have like multiple small ones, and not like one kind of blew up like that.
Right. So here's the second person. All right. So this is an interesting case. It was I don't remember how old the patient was, but okay. So you can see that in this patient, you can see that there is a mass in the left hepatic lobe. And again, you can see that the mass enhances very heterogeneously on arterial phase and avidly more than the liver. And by the time we get to the portal venous phase, it washes out. So enhancement pattern is the same or similar to the one that I showed you, the melanoma, also hypervascular mass. And notice that it's obstructing, biliary tree in this segment. Any thoughts? This is a very unusual behavior of this entity.
Maybe like a biphenotypic, like HCC combo.
Right, so biphenotypic, sure. The patient has no history of anything, like in terms of liver disease, which doesn't mean anything, but biphenotypic is of course. If we didn't see the biliary tree dilatation, what things would you think about with this pattern of enhancement?
HCC versus adenoma. I didn't see the arterial phase. I don't know if I only see one.
This is you were supposed to see in both. No, I'm
I only
sharing
see one
images.
image.
No?
Yeah, we only see the portal
Well,
views.
this is odd. Hold on one second.
Initially, we saw two, and then you clicked into. Okay, yeah, now we see two.
Hold on. Let me bring up the correct. And then there. Sorry, I didn't realize that it wasn't showing the. So here's the arterial, and here's portal. So with this pattern of enhancement, what do you think? Like, forget about the biliary tree.
Adenoma versus HCC versus MET.
Right,
Actually looks like an FNH.
No, you don't put FNH here because it washes out. See that? So yes, on arterial phase, it's like it has that FNH appearance, like lobulated, very, very hypervascular. But you don't want to say FNH whenever you see washout. So, like, forget about the biliary tree, right? So, without biliary tree, with this pattern of enhancement, I think HCC, I think hypervascular MET and adenoma. So, but this one also obstructed biliary tree. So, yes, I agree with you, Aarti. You would think about combined tumor. So, this is resected, and this is a grade 1 neuroendocrine tumor, what used to be called carcinoid of biliary tree. So, this is very unusual behavior of relatively common tumor, of neuroendocrine tumor. But the reason it was obstructing is because it was actually arising from the biliary tree, which is super, like I've never seen this before. So.
Wow, so it was a primary to the liver, like it wasn't a MET. Nice.
Yeah. It was like it was resected and it was like neuro. So interesting is it was a grade 1, and this is the original CT from ages ago, and now the patient has multiple metastases. So, it's interesting because you would think grade 1 means kind of better behavior, but in this case it's not a great behavior here. But this is very cool.
It reminds me of some neuroendocrines in the pancreas obstruct the duct, but they are the serotonin secreting ones. So if you see a hypervascular mass in the pancreas, but it's obstructing, it can still be neuroendocrine, but usually it's that is producing serotonin, which is what is causing the fibrosis.
Right.
Cool.
That's all I have.
Okay, Nellie.
This is an MRI. So this is an MRI of the pelvis. We were referred because of an abnormal ultrasound. These are the larger field of view, T1, T2, fat sat. This is diffusion. This is the high B. And then this is ADC. Here's the smaller field of view, T2 without fat sat. Here's the SAG.
Kind of crazy looking. Looks like it comes from the uterus. Is there, what was the T1 pre? Is there any hemorrhage in it?
T1 pre here.
So no definite hemorrhage.
No T2, T1 bright stuff. Here it is on the coronal.
I don't like it. I don't think it's like just a weird fibroid. I think it's some kind of, but I don't know. It doesn't.
Do we have contrast images? Yeah. So here's pre, kind of early post, later post, subtraction, not real helpful. Here's Sag. Any thoughts?
Leiomyosarcoma or some other kind of weird uterine-based malignancy.
Interesting, right? So
Yes.
I just looked up the path on this, and I feel proud of myself. Obviously, I didn't know exactly what it was when I was looking at it, so I gave it a differential. And my differential was complex degenerating leiomyoma or atypical feature for leiomyoma overlapping other benign or malignant things, including cystic adenomatoid tumor, which is a benign entity, or leiomyosarcoma. And then I said they should watch this closely if it's not going to come out. And it turned out to be a cystic adenomatoid tumor.
Wow.
Which I can share with you an AJR because I just looked this up. This was a case report from 2002, and there's similar features here of basically a cystic mass of the uterus. And what they say about them is very rare. It's been reported several cases. Only a few cases in the literature, blah, blah, blah. Anyway. And then they gave a differential. So I must have looked up a differential and was looking for, cases of this. Their case, maybe a little bit less complex than the one that I'm showing you. But if you see, I guess, a cystic mass in the uterus, especially if it's incidental asymptomatic, it could be quite complex even. It's in the differential.
Very cool. And no malignant potential.
No, these are benign.
Cool.
Cystic adenomatoid tumor of the uterus.
Nice. Okay, I'm gonna go. So this is a patient, female patient. They've had a hysterectomy and they have this mass. So this is just a companion case to the one that Akshaya showed earlier. It doesn't look as dark as her lesion. It's kind of intermediate to sort of hyperintense on T2. And it demonstrated pretty moderate enhancement. It's very restricting on diffusion weighted imaging. Really dark on EDC. Just show you this again. So here it is. So I'm not sure there's much to really clinch this diagnosis, but I just wanted to show you guys this since we have path on it. So we kind of thought that, this could be, it doesn't look like a leiomyoma. It's in the vulvar region. So we gave a differential of a leiomyosarcoma and also an angiomyxoma. Like Akshaya showed earlier, angiomyxoma tends to be more laminated and T2 bright, but can be avidly enhancing in this region. So this was biopsied and turned out to be a leiomyosarcoma. So I think it's going to need a biopsy either way, but that's what this was.
The T2 signal intensity is pretty high.
Yeah, that's kind of why we brought up the angiomyxoma one, but yeah, it was a leiomyosarcoma. So I guess anywhere there's muscle, you can get leiomyoma, but if it's brighter, you can get a leiomyosarcoma. Okay, let's stop for a second. Okay, so this is my next patient. You can see that they have severe hydronephrosis bilaterally. And it's been very chronic, so you see like almost no renal tissue. they actually had an ileal conduit to the bladder. And this patient had something as a baby. This male patient had something as a baby that causes severe hydronephrosis. So any thoughts there?
The valves are the most common, right? Posterior urethral valves, isn't it?
Yeah, exactly. So this patient had posterior urethral valves, and it caused this severe hydronephrosis. They ended up ablating the valves, but often the bladder is so injured in the process of like being so distended from the posterior urethral valves, which are basically at the base of the bladder in the prostatic urethra, that they ablated the valves. And because the bladder wasn't functioning well, they actually did a diverting ileal conduit to a urostomy. And then later on, they reconnected the ileal conduit to the bladder.
I
So
don't like
now-
the ileal conduit though.
Yeah, now many years later, this is what the ileal conduit looks like. So it looks really abnormal. We can see all this thickened soft tissue even going beyond the conduit. So we were concerned about malignancy. They also were in renal failure. Those kidneys weren't working, so they got a renal transplant. So the couple of things we brought up were it could be like a malignancy of the ileal conduit. It could be a urothelial tumor starting at those distal ureters and going down into the conduit, and it could be PTLD or lymphoma because of the renal transplant. So it was biopsied, and the interesting thing, I mean, it's really centered in the ileal conduit, so we were favoring that it could be a GI malignancy, although, you know, small bowel cancer is rarer. But this came back a poorly differentiated high-grade mixed neuroendocrine tumor and adenocarcinoma, and they called it an amphicrine tumor. And so I looked it up, and an amphicrine tumor is a tumor where the cells within each cell have both endocrine and exocrine function. Not like that's anything we would ever diagnose radiologically, but they are very aggressive. And they're generally of GI origin. So because it was amphicrine, we could tell that this was coming from the GI tract, the ileal conduit. So just kind of a and then even within a month, they had already developed liver mets. So we can just like kind of nicely see this the conduit with all this tumor.
Trying to remember the malignant risk for conduits. I think it's relatively low, but maybe above nil.
Yes, exactly. So it is higher than just like the general rate of small bowel cancer. I think because you have all this urine and stasis in the conduit, so there's going to be like more, you know, just dysplasia over time. Okay, I'm gonna pause. Okay, so this was a pancreas case. You can see the regular pancreas here, and then there is this mass. So, and then distal to the mass, you can see that the pancreas is like atrophic with dilation of the duct. So any thoughts about this mass? I can show you on the coronal if you want.
Kind of hard to, when things get big, it's hard to tell exactly where they're coming from, but it looks like it's coming from the pancreas, huh?
Yeah, the pancreas edge was here, and I'll tell you in the end, this was a pancreas mass. So if it's a pancreas mass, what are you thinking about?
Spin.
Good thought.
Endocrine.
Yes, excellent, especially big. So we wouldn't really think about adeno because it doesn't, you know, adenos don't usually grow like a ball like this. Any other thoughts? Okay, I'm going to show you the MRI. So I would say if I like, you know, if you see this, do you see how like there's maybe suggestion of like it's cystic and solid? So anytime you have cystic and solid, I would think about recommending an MRI because, you know, there's another differential in here.
Aarti, how old is the patient?
Oh, is it that papillary lesion that you presented before?
No. What do you guys think now?
Kind of looks like a serous now.
Serous cystadenoma.
Yeah, exactly. So it's a serous cystadenoma with like a central scar. It's lobulated. It's very T2 bright. So and I teach at the AFIP, and actually we have a lot of serous cystadenomas in the database that were pathologically resected because on CT they were called a solid mass and the MRI was never done. So I guess my public service announcement is if you see a cystic and solid mass, put serous in your differential and get an MRI because I think it can really help show the cystic nature. All of this enhancing, like sort of solid looking part is actually just like the enhancing septa that are really close together. And then you'll see the cystic nature much better on MRI. Okay. Okay, so this patient was recent postpartum. And there's something on this image. A place we're not usually used to looking, but here, back here, you can see.
Going to the spine.
Yeah, so there's
a catheter fragment in there.
Exactly. So I'll show you on the sagittal. So they had put an epidural catheter in, and you can see it just stops right there. So the epidural for the pregnancy, the delivery had basically snapped off when they were trying to remove it. So we saw it on CT, we told them where it was, how deep it was, and they had to go basically and do a cut down and remove it. IR was consulted, but didn't feel like they could, like fish it out just using like CT guidance or even fluoro guidance. So just a snapped epidural catheter. Okay, so this patient had a lung transplant. You can see they had a lung transplant. And the reason why, any of the fellows or trainees out there, based on this image here, can you tell me why they had a lung transplant?
Is it cystic fibrosis?
Yes, good. I heard it very faintly, but cystic fibrosis, and you can see complete fatty replacement or very extensive fatty replacement of the pancreas. So there are some acinar cells in here, but a lot of fat, and that's why it's expansile looking too. So they had that lung transplant, and they've been in the hospital for a while, and then this is what their colon looked like. So basically severe pancolitis. You can see that it's very thickened, hyperenhancing mucosa, but the house drawer preserved. The transverse colon also extremely thickened. Here, almost like an accordion sign. So, we briefly, they were also neutropenic. And so we thought about typhlitis, but usually that really only affects the cecum and terminal ileum and appendix. So anyway, this pancolitis, really severe, very, very thick. It was pseudomembranous colitis. And they ended up they were so sick. They didn't have toxic megacolon yet, but they were really sick. And so they took them to the OR and did a total colectomy. And it was severe pseudomembranous colitis. One thing I was just reading about in Radiopedia, I guess they renamed, it's no longer Clostridium difficile, it's Clostrioides difficile. I don't know what the difference is, but it's been renamed, the bacteria. And it's usually antibiotic related. So patients who are inpatient for a long time and have been on antibiotics, their normal gut bacteria is altered, and therefore this abnormal bacteria that we don't normally have is able to colonize the gut. And it creates pseudomembranes, and that's where you see all these thick wounds.
I have something to add.
Yeah?
About the renaming process.
Oh, yes.
So apparently, like when they were renaming it, based on whatever molecular taxonomy situation, it was supposed to belong to, I don't know, it's gene or whatever. So the name was supposed to technically not start with C, with some other, part of another family that it was supposed to fall into, like based on whatever molecular stuff that they found. But then they decided that renaming it it would have been like T difficile or something like that. I remember the first name, D, I don't remember. But they decided that it's so ingrained for people to call C difficile, so that they changed it to Clostridioides, even though it's not super correct. So
Oh.
just so that it would still stay C. difficile. So that's whatever.
Okay, cool.
Because
I always
they just figured if they rename it correctly, like nobody's gonna just change. But so now it's like the full name is changed, but you can still say C. difficile without bothering, that the rest of the C is changed.
I like that. I always tell my residents, like, it's better to be clear than like extremely correct. Like, even if it's technically correct. Like, for example, the word nauseous is not a word, it's nauseated, but like, it doesn't really matter because everybody uses it now, But anyway, okay, let me stop.
I know the CFers, they get a colopathy sometimes, not as severe looking as this, but I haven't shown one of those on a film panel, like a fibrosing colopathy of cystic fibrosis or something.
I know they get DIOS, distal intestinal obstruction syndrome, because they don't have like the proper mucus. So like they get basically like fecalization and obstruction of their TI. But yeah, if you can look up what they get in their colon, I didn't know about that.
Yeah, I'll try to.
Okay, I'll pull up my other case while you're doing that.
Okay.
Okay, this is just a quick one. This patient has leukemia and presented with right lower quadrant pain. And this is just a companion case to the one I just showed, but this was a case that we thought was typhlitis. So you can see that their cecum has the submucosal edema and mucosal enhancement. And in the severely neutropenic patient, when they have inflammation of their cecum, we call it typhlitis. You can't apparently use that term if the patient is not immunocompromised. And if they're not neutropenic. And what typhlitis is basically a break, like you get a bacterial infection and transmural translocation of the bacteria, and your body's not able to fight it off because you are neutropenic. It's not really known what causes it, but a few possibilities are ischemia, infiltration of leukemic cells, as well as infection, especially with CMV. So if you see just inflammation of the cecum, appendix, TI, in a neutropenic patient, that's when we call it typhlitis. Okay, that's it for me. Steve, did you find out anything?
Yeah, sort of. I think you were onto it more than I was. Yeah, let me share screen real quick, see if I can find this screen here. So this is an AJR article about abdominal manifestations of cystic fibrosis in adults and children. And the case I was showing on the film panel was something like this one, which is that this one's an intussusception, or maybe it was more like I don't know, there's this one, which they described as a distal intestinal obstruction syndrome, which there I guess it's affecting the ileum and right colon.
Yeah, and that fecalization and stuff is a clue. Because they're like not absorbing things properly.
That's right.
Their enzymes are off. Cool, thank you.
You're welcome.
Okay, Nellie.
And I'm back, so I'll share after Peter finishes.
This is a 67, just like a 67-year-old male with a mass. So I'm assuming everybody can see. This is an outside scan, but we got the path on this, so I thought it would be interesting. Any thoughts?
What's the T1?
So that's the T. That's all we have.
Great. Maybe melanoma again?
No. And here's the post contrast.
Or just?
So that's what was it just? So it actually turned out to be a leiomyoma of the rectum. So
It looks kind of like the same T2 as my leiomyosarcoma.
yes.
Maybe a little darker.
Okay.
But it does look submucosal, so I buy it.
Yeah. Well, I mean, it's a path-proven one, so. Okay.
So this is not really an eye test. And here are the
Main duct IPMN.
yeah. So I'm going to show you the MRCP images. So on the MRCP images, the main duct is. I hear an echo on my.
I just muted some other people.
Oh, thank you. The main duct is markedly dilated. There's also like side branch cystic lesions as well. And then when we approach the pancreatic head, there's a stricture right there. And then you can see the proximal pancreatic duct inserts into the ampulla. So this stricture, so there's all of the cystic. So this is, and this was EUS and positive for pancreatic adeno-CA. Probably arising from mixed main duct IPMN with that malignant stricture where the EUS was positive.
Can you scroll? That's beautiful MRCP. Can you scroll through again? So do you know if they're planning to do just a Whipple or a total pancreatectomy?
Pending.
Okay, because I used to think like they used to say like you would do a total, but most of the time now they'll try to take out like the most concerning part of the gland and try to preserve some of the gland so they don't get brittle diabetes. And it looked like the tail isn't as engorged and maybe like could be salvaged. Apparently you only need like, I think 25% of your islet cells to make enough insulin.
I didn't know that.
Yeah, so they could probably save that last part and then like at least then monitor it for the rest. Nice. Okay, anyone else? Okay, great to see you guys. See you next week. Bye.
Thanks all.
Thank you.
Bye.